Dr. Syeda Farzana Yesmin, Associate Professor, Gynae Obst at the Akij Medical College, Khulna. Today's my topic is abortions, different types of abortions. First of all, I will discuss about threatened miscarriage or threatened abortion. It is a clinical entity where the process of abortion has started but has not progressed to a state from which recovery is impossible. Clinical features of these patients include when a patient attend with the symptoms of pregnancy, complaints of parvaginal bleeding. Bleeding is usually slight and brownish in color. Occasionally bleeding may be brisk, especially in the late second trimester of pregnancy. Bleeding is usually painless but may be associated with a dull pain, low back pain, and other features of pregnancy, other symptoms of pregnancy also associated with these features. In case of examination, in such cases, we prefer ultrasonography to diagnose the case of threatened abortion. But in situations where ultrasonography is not available, we do clinical examination. In case of clinical examination, parvaginal examination help us to differentiate different types of abortion. We always want to do ultrasonography to diagnose the type of abortion, but in situations where ultrasonography is not available, we do parvaginal examination. In such parvaginal examination, we first do bimanual examination. In case of bimanual examination, we find the size of the uterus correspond with the period of amenorrhea. In case of gentle paraspeculum examination, we found the parvaginal bleeding escaping through the cervix, which is slight in amount, and cervical os is closed. When we try to feel, cervix feels firm and the os is closed. Now we try to do ultrasonography when available. Sonographic features are just a well-formed gestational ring having a central echo, which indicates a embryo with a central echo. Gestational ring, well-formed gestational ring with a central echo indicates a healthy fetus, healthy embryo. And in such cases, when pregnancy is beyond 6 weeks, we found fetal cardiac motion, fetal movements. But in case of blighted ovum, which is a sonographic diagnosis, having a gestational ring without a fetus, the sac diameter is 3 cm or more, but no embryo within the gestational sac, then we call it blighted ovum. So ultrasonography also help us to diagnose a case of blighted ovum. In cases of other investigations, we do routine blood investigations, blood examinations, which includes blood grouping, Rh typing, CBC, RBS, serum TSH, SBSAG, VDRL, etc. Every investigation has its value. In case of blood grouping and Rh typing, it helps us to differentiate whether the patient is Rh positive or Rh negative. If the patient is Rh negative, we do NTD antibody titer. If Rh negative antibody titer is negative, then in case of abortions, we give NTD gamma globulin to the patient to avoid Rh isoimmunization. Also, if the patient need any blood transfusion, we can give her blood transfusion. And other investigations to know whether pregnancy is continuing or not, we can do hormone level. Hormone levels, especially serum progesterone level and Serial estimation of serum beta HCG level. In case of serum progesterone level, if serum progesterone level is 25 nanogram or more, it indicates the pregnancy is continuing. Indicates a viable pregnancy in about 95% cases. In a case of serial estimation of serial beta HCG level, if the serum beta HCG level is increasing, gradually increasing, it indicates a viable pregnancy. In case of treatment, we first advise her absolute bed rest until the bleeding stops. Bed rest, we should ensure bed rest. Then, as the woman is a anxiety state, we prescribe them anxiolytic sedative like phenobarbital, 30 or 60 milligram phenobarbital as a sedative. And in studies show in such cases we can give them progesterone support, and it helps in immunomodulation, pro-inflammatory response to anti-inflammatory response. Progesterone helps to induce pro-inflammatory response to anti-inflammatory response. Advices on discharge. When we do discharge the patient, we should give them some advices which should be followed. She should limit her household activities and heavy strenuous work for at least 2 weeks. Coitus should be avoided for the same duration, and she should be followed up after 3 or 4 weeks with a ultrasonography and progesterone level, serum beta HCG level. In follow-up, the investigations shows the well-formed gestational sac. In case of ultrasonography, we find a well-formed gestational sac having a fetal pole and fetal cardiac motion, fetal movement present. In case of beta HCG level, increasing or rising level of serum beta HCG indicates a viable pregnancy. Prognosis. Prognosis of threatened abortion is unpredictable, very unpredictable. In isolated spontaneous threatened miscarriage, the following events may occur. This includes, in about 2/3 of the cases, pregnancy continues beyond 28 weeks. But in 1/3 of the cases, the threatened abortion terminates in inevitable and or complete abortion, or may be changed into missed abortion. In about 1/3 of the cases, threatened abortion is terminated in complete or inevitable abortion, or may show features of missed abortion. If pregnancy continues beyond 28 weeks, it may ultimately end in preterm labor, may develop placenta previa, intrauterine growth restriction, or the fetus may develop by having any fetal congenital anomalies. Inevitable abortion. What is inevitable abortion? It is the clinical type of abortion where the changes have progressed to a state from where recovery is impossible, or from where continuation of pregnancy is impossible. The clinical features of inevitable abortion, the features may include patient of threatened abortion when present with increased PV bleeding, or the aggravation of lower abdominal pain. Then we do the examination, physical examination, and on internal examination, in case of inevitable abortion, internal os is found open and product of conception is felt through the open internal os. So, a case of threatened abortion may present with features of inevitable abortion. In few cases, the inevitable abortion develops suddenly without any feature of threatened abortion. Or in case of second trimester abortion, the inevitable abortion may develop after developing a feature of premature rupture of membrane. So, in case of management of inevitable abortion, we usually accelerate the process of abortion and we maintain strict asepsis. Active management in case of general measures of these inevitable abortion include when the bleeding is brisk or profuse in amount, we can give argometrin, methargine 0.2 milligram to reduce the amount of bleeding. And if the blood loss is profuse, we also give transfuse blood and or fluid to maintain the volume. In case of active management of inevitable abortion, if the pregnancy is before 12 weeks, management differ from the management after 12 weeks. Before 12 weeks, we usually do evacuation and curettage. We also do suction evacuation and curettage. This is usually done under general anesthesia or deep sedation. After 12 weeks, we first give oxytocin drip, usually 10 to 20 unit oxytocin in 500 ml normal saline at a rate of 30 drops per minute. If the fetus is expelled, but the placenta is retained inside the uterine cavity, then we remove the placenta with a ovum forceps or a sponge holding forceps. If the placenta is not separated, we first separate it digitally, then remove it with a ovum forceps or with a sponge holding forceps. This is done under general anesthesia usually.